Well, good afternoon. So today, my talk is going to be the complications of hematopoietic stem cell transplants. So I've introduced some cases. I've talked about the relevance of transplant in several slides and some evolving therapies and just their complications. All right, so the first slide is a commercial. Since Methodist and CHI support the pink out for Creighton, the 25th is the next game, and this is my friends and family. So unfortunately, they're not doing very well this year. So the first patient is a 63-year-old female who had with international stage 2 myeloma that had high-risk chromosomes. She had a 14-16 translocation. She received induction chemotherapy with lenalidomide, bortezomib, dexamethasone, referred to as RVD. She developed renal failure with induction therapy, which resolved. Her pre-transplant evaluation had 2% plasma cells. Her monoclonal protein was gone. She was collected with Cytoxa mobilization, and she received high-dose single-agent melphalan. Day 4 of her transplant, she developed fever, shortness of breath, hypotension. She had a rash, confusion. She was transferred to the ICU in septic shock. Cultures were all negative, by the way. However, her CMV, she had 4.8 million copies. Normally, we don't look for this. She developed respiratory failure, was intubated, required a trach, developed renal failure, required hemodialysis. Now, this is the type of patient we don't want to see, but historically has over a 90% mortality rate. But this is a reason I put this case up and started with it, is this the testament of the good nursing care, because this patient left the hospital and at 1 year is doing well. I don't actually follow her anymore, but she's doing well. So this was her chest x-ray, and you can see there's all this whiteout in appearance. So this person developed engraftment syndrome, had sepsis, cultures were negative, CMV. You don't get sicker than this. This is what patients with, I want to talk on this? Oh, sorry. These are the patients with allogeneic transplants typically get. All right. So what are the causes of mortality associated with transplantation? Well, the number one reason is relapse disease. So that's a failure of the high-dose chemotherapy, but relapse disease is a big issue. Infections, about 8%, organ failure, 4%. Secondary malignancies are increasing in frequency, and we'll talk about that. And other complications will be liver failure, lung toxicity, or cardiac. So the indications for autologous transplant really hasn't changed in a long time. The number one reason to have an autologous transplant is multiple myeloma, followed by lymphoma, both Hodgkin's and non-Hodgkin's. Acute leukemia is rarely done anymore. The only solid tumor is testicular cancer and autoimmune disorders. We used to do, the most common reason to have a transplant was breast cancer, and the randomized trials show that that was an ineffective therapy. So when we collect stem cells, there's several protocols that we follow, and they're all associated with some unique side effects. We use cyclophosphamide or high-dose Cytoxan, prednisone, and G-CSF. It's a fairly predictable way of collecting adequate stem cells. For patients who still have a fair amount of high tumor burden, we use high-dose cyclophosphamide, etoposide, and G-CSF. You can use just Neupogen or G-CSF alone, or you can use Plexifor with G-CSF. So when they collect stem cells, they use the cell separator, which is here. You could either use arm veins or a central line. This is a patient I transplanted a long time ago, so I still use this slide. The machine is actually quite a bit smaller. Oh. All right, and this is what the stem cells look like once they're collected, and then they're frozen indefinitely at 170 degrees. But with stem cell collection, there's some unique side effects, infections being the one concerning because they're neutropenic. for part of the collection. They have a foreign device and having a large apheresis catheter. Bleeding is not a huge problem because we transfuse platelets if the platelet count is 50,000. 1 in 2,000 patients will develop a cardiomyopathy related to the Cytoxan. It's some genetic issue. Hemorrhagic cystitis is 1 in about 10,000 patients. Bone pain is common from the Neupogen, and 1 in a million patients will develop splenic rupture. So I haven't seen that, but when we consent patients for mobilization, these are the side effects we go through. So this is a patient, a 70-year-old male with standard risk myeloma, international stage 1. He received induction therapy with RVD. He had cyclophosphamide G-CSF for mobilization. He had plenty of stem cells. An adequate stem cell dose is 3 million per kilogram. He had 12 million cells. But on day 16, so when he received the Cytoxan, you collect around day 10, and then we wait 2 weeks. He presented with hematuria. He had the cystoscopy, and you see all this red area. He developed severe hemorrhagic cystitis. We delayed all his therapy for 2 months, and I was concerned that there was going to be a big problem with this transplant. He went on to high-dose single-agent melphalan without events. He actually had no complications with his transplant. He became confused for about a day and had rapid hematopoietic recovery, did not require any blood products, and I think he's 1.5 years, and he's in continuous remission. So hemorrhagic cystitis is related to the byproduct of cyclophosphamide. Cyclophosphamide is a prodrug. It's cleaved in the liver into an active metabolite and acrolein is what causes this problem. We give Mesna to prevent this problem, but in this case it was a big issue. So I've mobilized 150 patients, and 2 have developed that problem. So I'm going to talk a little bit about myeloma and is transplant relevant, right? So we don't want to go through side effects if it's not. So these are a bunch of plasma cells. So before 2000, this was the outcome for transplant. With regular chemotherapy for myeloma, nothing really worked. No matter what you gave, it was all the same. We treated patients as if they had breast cancer. We didn't realize the uniqueness of this disease. So the average survival was 30 months. Then in 1996, the French, and I'm only going to talk about the French trials because they're much more organized than the US trials. They did the first transplant trial with 200 patients, 100 patients, and these were all under 65 years of age. So in Europe, if you're over 65, you're considered ancient and you do not get transplant. So this trial looked at conventional dose chemotherapy, and we don't use these drugs anymore, and high-dose chemotherapy. And the significance of this trial is that the first time event-free survival or time without myeloma was actually plateaued. So at 8 years, 25% of the patients remained disease-free, where on the conventional dose chemotherapy, none of the patients were disease-free. And it also showed a survival advantage where 50% of the patients at 8 years were alive, where in the conventional dose, less than 10% of patients were alive. So when we look at transplantation, typically the average time to stay in remission is 3 years. So how do you improve that? So this is a trial that was designed to eliminate stem cell transplants for the diagnosis of myeloma. And Natal, with 77 transplant sites in Europe, did this randomized trial where patients received RVD or lenalidomide, bortezomib, dexamethasone, followed by autologous transplant. 700 patients were included in this trial. 350 had RVD for 5 cycles, so that's 5 times 3. So 3 weeks is 1 cycle, 5 times, versus 3 cycles of RVD followed by high-dose chemotherapy. And everyone received 1 year of lenalidomide. So this trial showed, and I'll just point to these, complete remission rate was significantly higher in the transplant arm. And when you look at complete and partial response, and this p-value of 0.01 is highly statistically significant, showed that complete response rate was 88% versus 77%. So this was better. When we look at progression-free survival, which really was the endpoint of this trial, if you look at the blue line on top, the transplant arm was superior to standard chemotherapy. Now the difference between this chemotherapy regimen and the chemotherapy in 1996, they gave an adriamycin-based chemotherapy, which we don't do anymore. Revlimid is actually Velcade, dexamethasone, are myeloma-specific drugs, so response rates are much higher than they were in 1996. But this showed a statistically significant improvement for transplant, whereas overall survival, there is no difference. But if patients were followed for 4 years, they probably need to be followed for many more years to see if there's a change in curves. But this trial did not achieve the goal of eliminating high-dose chemotherapy. So this is a standard study that shows who was involved with the average age was pretty balanced, 55 to 60. The type of myeloma was balanced in both groups, the type of myeloma and the chromosomes, and they were the results. So it turns out that every subset, regardless of age, type, chromosome, or stage, was better with high-dose chemotherapy. So this is a hazard ratio that shows that transplantation is better than just standard chemotherapy. So these are the side effects. As you would expect, the side effects associated with transplantation were significantly higher. Neutropenia, infections were statistically higher in the transplant group as aligned in this group. Nausea and vomiting was higher. Infection rate was higher. Pulmonary toxicity was higher. Painful peripheral neuropathy was equal in both groups because the patients who had neuropathy at presentation had it during the transplant, and blood clots were actually higher in the transplant group as well. So this is the schema when we transplant patients. So we give single-agent melphalan over 15 minutes. The next day we give the stem cells back, and you can see the white count goes up. So typically the average white count is 25,000. These are cells that are functional, and the counts go down to 0 for about 4 days. And there's some side effects that everyone has: nausea, diarrhea, mouth sores, fever, requirements for blood transfusions. And the bad ones we'll talk about in a minute: cardiac arrhythmias, pulmonary side effects, renal failure, and bleeding. And the reasons we discharge patients is they have to have no active infections, no diarrhea. They have to be eating and ambulatory. So we divide infectious complications of transplant into infectious and non-infectious. So early we have infections, bleeding, GI side effects, mucositis, nausea, vomiting, pulmonary, cardiac, hemorrhagic cystitis, and Grafman syndrome. And late, and the most relevant one, is relapse. But you can have infection, graft failure, gonadal failure, secondary malignancy, and toxicity. So I'm going to talk about most of these individually. So with infections, they typically go with engraftment. So engraftment takes anywhere from 17 to 14 days. And this is when your neutrophil count is greater than 500. So 30% of patients will have a fever, and 30% of those will actually have a bacterial infection. The skin is probably the most common source of infections. You have these foreign devices, the apheresis catheters, so coagulus-negative staphylococcus is probably the most important. Oral pharynx, you have strep viridans. In GI, you have enterococcus, gram-negative organisms, and candida. So this is a public service announcement. Since it's the flu season, it's still not too late to get a flu shot. And in fact, I give patients flu shots twice per year as long as the flu shot is effective. They don't have aviation gin on this one, but that's probably the best. So I'm just going to talk shortly on this. So you give your conditioning regimen. In our case, we use melphalan. In lymphomas, we use BEAM, which is BCNU etoposide Aricea melphalan. You have chemotherapy-related nausea, you have mouth sores, you have elevated liver function test, and you have chemotherapy-associated diarrhea. I'll talk about the rest. So just to be balanced, I put Nebraska on here. You'll probably think this is, I put this on for Dwayne Wade and Gabby Gifford, but my patient sent this because I was standing behind him. So I thought that was more important. So acutely, there's the nausea risk or emetogenic potential, and you could divide these drugs by their risk. So the highest emetogenic potential is BCNU or carmustine, receiving greater than 250 milligrams per meter squared, and we use that for our lymphoma protocols. Cyclophosphamide is highly emetogenic, so we modify our anti-nausea protocol based on that. Busulfan, cytarabine, we don't use busulfan, but melphalan is kind of a moderate emetogenic risk, and etoposide is low. Mucositis, probably the most common reason for mucositis or dysphagia is viral reactivation, CMV, HSV, varicella, and Candida. And so we culture everyone's mouth prior to treating because we don't want to see this. So this is a patient's mouth on day 10 post-transplant, and you can see the ulcerations along the tongue and lip. And ways to prevent this, we give everyone cryotherapy. We have them suck on ice cubes 20 minutes before, during, and after. We haven't used a keratinocyte growth factor inhibitor, also prevents this, but that's $10,000 and the ice is free. You could use bicarbonate rinses, aluminum hydroxide, topical anesthetics. We use niacin and Paradex. And this is something we used to see routinely where you'd have sloughing of the mucosa, where the tongue hurts. Many of these patients end up having to be intubated to protect their airway. You have bleeding in your tongue here. It may not project very well, but this is Candida. And so we don't see Candida anymore because we actually surveil patients and we either start them on mycofungin or diflucan. So here's a case, 65-year-old male with IgG lambda myeloma. He had actually standard risk disease in terms of chromosomes. He was treated with Velcade, Revlimid, dexamethasone. He had his transplant in 2015. On August 15th, he had a bone marrow, totally normal in terms of no myeloma. He had decreased megakaryocytes, chromosomes were normal, fish were normal. He then presented with pancytopenia, required blood transfusions. He's had over 70 red blood transfusions and about the same number of platelet transfusions. He was treated with IVIG, Nplate, and cyclosporin. In 2016, he had a bone marrow biopsy that showed no myeloma, but he had decreased megakaryocytes. Now, megakaryocytes are the cells that make platelets. So without megakaryocytes, you don't have platelets. September 2016, he had a normal cellular bone marrow. He was in remission. He then had his bone marrow repeated June 6, 2017. It was hypercellular. His red cells to white cell ratio was normal, and his megakaryocytes were actually normal. His chromosomes were normal, no evidence of myeloma. However, in June, he had an elevated PSA, had a biopsy, and had adenocarcinoma of his prostate. He elected, at the time, no treatment and took testosterone instead, which he's now being radiated. He's off his testosterone. He also had squamous cell carcinoma of the skin. So this patient actually identifies two complications. Graft failure is 1% of patients. And then secondary malignancies, we'll talk more about that. So this is what his bone marrow looked like. This is his bone marrow shortly after his transplant. Lots of cells, and these little large cells here are the megakaryocytes. This is his bone marrow later, which basically just see fat, right? So you don't see any there may be one megakaryocyte here. So graft failure is an unusual complication. Bad complication, high rate of infections, because you have infections, bleeding, increased transfusions. Because he had 75 red cells, his ferritin was 2,500, and normally give an iron chelator, which he refuses to take. The second problem with people who have graft failure is myelofibrosis. So certain disease like myeloproliferative neoplasms, they have fibrosis, or patients with CML have fibrosis, and about 1% of patients with myeloma and lymphomas will have fibrosis. Viral infections, human herpes virus 6, and parvovirus, and probably unknown viruses are a cause for graft failure. And probably the number one reason to have graft failure is having recurrent tumor, whether it's myeloma, lymphoma, leukemia. That's a good way to lose your graft. So these fish were somewhat surprised. And so this is the next patient, 61-year-old female with international stage 1 disease. So having trisomy 9, 11, 15q were considered good prognosis. The patient was treated with upfront with cyclophosphamide, Velcade and dexamethasone, or Cybord-D. She then went on to high-dose melphalan. She was transplanted somewhere else, but then was placed on maintenance lenalidomide or Revlimid. 9 months post-transplant, she presented with shortness of breath. And this is the CT scan where this white fluffy infiltrate, you can see through here, is not normal. So pulmonary complications can occur in 40 to 60% of patients post-transplant, and partly depends on underlying disease, previous treatments. Patients with Hodgkin's disease get bleomycin, which increase your pulmonary toxicity. We look at baseline pulmonary function, we look at DLCO. If they're abnormal, you have a higher risk of pulmonary complications. And the conditioning regimen, so carmustine used to be used routinely in transplants for breast cancer, and dose mattered. We used to give those patients 900 milligrams per meter squared of BCNU. At 10 months, they'd present with cough, shortness of breath, that he developed pulmonary fibrosis. We've now reduced the dose to 300. We don't see that. Etoposide and melphalan have similar side effects, but much less complicated. Busulfan is a cumulative effect. So interstitial pneumonitis is direct damage by the chemotherapy to lung tissue. It can occur within a few days of treatment to several months. Patients present with a non-productive cough, dyspnea, and exertion. We perform a bronchoscopy to exclude an infection and start high-dose steroids. So the viral complications are cytomegalovirus, herpes, human herpes virus 6, parainfluenza, influenza A, B, RSV, and pneumocystis. But the non-infectious causes are diffuse alveolar hemorrhage, and when they do a bronchoscopy, you just see diffuse bleeding. Cause unknown. We assume it's toxicity from the high-dose chemotherapy. You can develop interstitial idiopathic pneumonitis, pulmonary edema, pulmonary fibrosis, pulmonary embolism, and hypersensitivity to drugs. So this patient actually represents two features. The bronchoscopy, cultures were negative. The PCR was positive for pneumocystis, but they had high levels of eosinophils in the bronchoscopy, and it was thought to be related to hypersensitivity to lenalidomide, and that occurs in about 2% of patients.
And this was 6 months after?
6 months post-transplant.
So how long do you have to wait for these?
You can see the complications years afterwards, right? So it's important to remember they've had a transplant, and they call someone that's experienced with transplantation. Probably the worst thing I ever was in a case I was involved with. I had a young woman who had leukemia. That I did a cord blood transplant on her. Complete remission. At 10 months, she went to her primary care doctor for a fever and cough, and they put her on Mucinex. 3 days later, she was on a ventilator, right? So identifying the delayed complications are very important. So it could be years later. So this is Kyle Korver. He's fourth and third point leading He just surpassed Curry, I think, yesterday. And this is our MVP, Charles Turnett. So we're going to talk about GI side effects. So this is a patient that we transplanted. So he's a 63-year-old male with IgG, international stage 2. He has high-risk myeloma. He was treated with daratumumab, cyclophosphamide Velcade as part of a trial. On day 2, he was admitted to the hospital, had a fever, cough, nasal swab, RSV. Day 10, he had severe diarrhea, and he had E. coli with a toxin was identified, and he only ate hospital food. And this is the CAT scan. So liver was normal, stomach was enlarged. You can see diffuse edema throughout his colon. Right, that's not normal. You shouldn't actually see the bowel walls. So, what are the side effects? We can have early liver function tests. They're usually drug toxicity related to conditioning like cyclophosphamide. We don't use total body radiation, but many places still do. Busulfan and melphalan. The azoles for antifungals, diflucan, sepsis, ischemic liver from hypotension, and sinusoidal obstructive syndrome. That used to be called veno-occlusive disease, and I'll talk more about that in a minute. So late effects are from drugs, infection, and VOD. Post-transplant diarrhea, we're all familiar with this. Virtually everyone gets diarrhea. 100% of patients get diarrhea, and most of it is from the conditioning regimen. We don't see much mouth sores because we use ice. I want to put NG tubes down and put ice water. Most patients don't want to do that, but the melphalan's major side effect is GI, so they get severe diarrhea. But there's other causes of diarrhea as well. Antibiotics, everyone gets placed on antibiotics. Opioid withdrawals, proton pump inhibitors, magnesium salts, and Reglan. Infectious complications are Class C difficile. That's probably one of our biggest problems. So in autologous transplant, 5.8% of patients will culture out C. difficile. In the United States, 14,000 Americans die from C. difficile, and over 400,000 patients are diagnosed with C. difficile. E. coli is our second cause. We do a panel like 30 bacterial and viral infections. We haven't seen any viral infections in our patients, but the ones you think about would be rotavirus. And so this is this patient we just talked about. Luckily, his chest x-ray was normal. He was treated with ribavirin, and his ribavirin, I'm sure, helped contribute to his GI side effects. So we treated him with ribavirin. He had a slight delay in engraftment. He did not develop pneumonia, did not need to be on a ventilator. He did develop AFib and had to be treated for that. He got transferred to like 5 different rooms during his stay, and then ended up on 6th floor and went home. He just returned from the Philippines, and he skateboards routinely. I think he's a little crazy, but he's doing just fine. He's in remission. His day 100 bone marrow was normal. So VOD, or sinusoidal obstructive syndrome, is a bad complication. We're fortunate that we haven't seen it, but this is associated with a high mortality rate. Patients have a large, tender liver. They present with elevated bilirubin, usually low platelet counts. They weight gain. It's about a 5% incidence, and this is because of endothelial damage from the preparatory regimen, and you have a hypercoagulable state. So the risk factors are typically pre-existing liver disorder, chronic viral disease, which we treat, but you still have, whether you have hepatitis C or hepatitis B, they get antiviral agents before treatment, alcohol-related hepatitis, fatty liver, cirrhosis. A small percentage of patients will have their bone marrow will be growing in their liver. We call it extramedullary hematopoiesis. Patients who have had previous radiation to their liver for whatever reason and had lots of chemotherapy. So the drugs that cause this are Mylotarg, which is used for AML, having radiation. The byproduct of cyclophosphamide acrolein the same agent that causes hemorrhagic cystitis, busulfan and melphalan. Bad complication, do an ultrasound, you have reversal of flow in the liver, high mortality rate. So we treat this with supportive measures. We used to use heparin. There's some data using antithrombin 3 infusions, and diflumpatide is an agent that works for this. And no one knows how it works, but it actually inhibits inflammation in the liver cells, the endothelial cells of the liver, and increases local TPA. So that's the drug of choice. So cardiac complications, it depends on your baseline cardiac history. If you had a previous MI, have AFib, all these complications are much higher. But less than age 50 patients that go on auto transplant, the incidence is 5%. Greater than 50, it's 25%. So we do a stress test in everyone prior to proceeding to transplant. So we try and weed out the patients that are going to develop something bad. So everyone gets an echo stress test. Cardiac arrhythmias occur in less than 5% of patients. Myocardial infarction about 1%, and pericardial effusions 2%. So patients with myeloma can develop heart failure. And the reason they develop heart failure because they have undiagnosed amyloid. So patients who have amyloid in their heart that undergo transplantation don't do very well. So that's a contraindication for a transplant, but they present with heart failure and do quite poorly. So we normally call cardiology, they put them on antiarrhythmic agents, and they typically only need to be on the antiarrhythmic agents for 3 months and then recover. So TTP, this is the blood smear of a patient who's developed TTP, and this is thrombotic thrombocytopenic purpura. So this blood smear shows, this is what a normal red cell looks like here. This is normal white cells, but you can see these fragmented red cells. That's called microangiopathic hemolytic anemia. And normally in the background you'd see purple dots, and this person has no platelets. So TTP is patients present with fever, microangiopathic hemolytic anemia, what that blood smear showed, low platelet counts, their Adams 13 is usually quite low, they have renal dysfunction, neurologic changes. In transplantation, this is associated with a very high mortality rate. Plasma exchange appears to be ineffective, still done. Exolizumab, Stellaris is a complement change, which actually has improved outcome by 50%. And doxycycline appears to work for this. I reported this a few years ago in the Lancet, and 80% of the patients responded. We have no idea why it worked, but the patients got better. So doxycycline is an antibiotic that has antimicrobial effects, but you can cut out the part of the compound with antimicrobial effects, and there's significant anti-inflammatory effects. So you may know some patients that have rheumatoid arthritis that got better with doxycycline, and that's the reason, not because of the antimicrobial. So another patient, 43-year-old female with high-risk myeloma. She presented with hypercalcemia, renal dysfunction. She was treated with Revlimid, Velcade, dexamethasone, had high-dose single-agent melphalan at another institution. And she had the Leeson 17, which is a very bad chromosome. She presented to the emergency room with shortness of breath. Her creatinine was 1.2. She had a CAT scan with contrast that showed no pulmonary embolism. Her calcium was 12. Her capillary chains were 3,300. Normal should be 1.5. 1 week later, she presented to my office with weakness. Her serum creatinine was 5.8. Her calcium was still 12. She got Zometa. Her capillary chains, I said, was 3,300. We did a bone marrow, 60% plasma cells. She was treated with plasma exchange to reduce her light chains as quickly as possible. She required dialysis for a short while, and then we treated her with daratumumab, which is a monoclonal antibody to CD38, which has Velcade and dexamethasone. I just saw her last week. Her creatinine is 1.3. Her capillary chains are 8.2. I've sent her to the University of Pennsylvania for consideration for for a transplant, for a CAR T cell study with CRISPR technology. So this is not an uncommon problem in transplantation, having renal dysfunction, and there's multiple mechanisms of action. Some of the angiogenesis drugs like lenalidomide, thalidomide, Revlimid can affect the glomeruli, and so you get fibrosis. The drugs we use for hypercalcemia, Zometa, pamidronate, and Xgeva, can affect, cause sclerosing in your kidneys, and cause proximal tubular dysfunction. So for transplantation, we worry about tumor at presentation. We look at DIC, elevated calciums. But the reason I put this slide in most is to highlight nephrotoxicity from contrast. So this is a person that had high light chains, but she had contrast, had a diagnosis of myeloma, and did not receive fluids either before or after. So normally patients with myeloma we treat with, if you can do whatever you want to them, but I make sure they get fluids before and after. And you reduce the risk of having nephrotoxicity. This is one of the complications no one seems to care about, but you see ridges in your fingers, toes, you clearly get hair loss that comes back. And this is a mental deficit disorder associated with transplant. Now this is a live shark. You can notice someone took the gaff out of him and the tail hit me in the back. And so I jumped from there to the other side of the boat. But patients with transplant can have memory loss that are short-lived. You can have seizures that are short-lived, but it's something we don't really, people talk about as chemo brain, but since you get one dose of chemotherapy, it typically gets better. So this is a 56-year-old patient with IgA kappa myeloma. He only had Revlimid dexamethasone. This was before Velcade was available. He had standard risk chromosomes. He had 200 milligrams of M protein forever. His bone marrow had 2% plasma cells. He was then placed on lenalidomide, continuous for 8 years. He presented with a platelet count of 25,000, and bone marrow showed acute leukemia with complex chromosomes, virtually untreatable. So this is a patient who didn't respond to induction therapy ×2 and succumbed to his disease. So lenalidomide, so secondary malignancies are an issue. This trial kind of was the trial that highlighted that. This is a TALS trial that was reported in the New England Journal in 2012. It includes 67 European sites and patients. There were 614 patients enrolled, all less than 65, all had responsive myeloma. All these patients had single-agent melphalan, and they were randomly assigned to placebo or lenalidomide. And lenalidomide was started at day 30 of transplant, and at 25 milligrams at day 100, reduced to 10 milligrams. The primary endpoint for this was progression-free survival. And this trial showed that patients who received lenalidomide post-transplant had a 3.1% increased risk of malignancy. So 32 patients developed secondary malignancies, whereas placebo was 11, and their risk was 1.2%. So if we look at the types of diseases, the hematologic diseases, we had acute myelogenous leukemia and MDS. We had acute lymphocytic leukemia, Hodgkin's, and non-Hodgkin's lymphoma. None of these patients did they do Epstein-Barr virus typing. This was just a descriptive trial. And then there were some other solid tumors. Also, the criticism of this trial is patients didn't have documented mammograms on time. They did not have colonoscopies. So on this, they had esophageal cancer, colon, prostate, breast, lung, sinus, kidney, melanoma, and non-melanoma. So this reflects my patient that we talked about with graft failure. He developed prostate cancer and he developed a non-melanoma skin cancer. The last patient I talked about who was on lenalidomide for 8 years, this trial was designed for lenalidomide continuously as well. He developed a very bad leukemia, and they didn't describe what types of leukemias these patients had in terms of their chromosomes, but they tend not to be treatable. We looked at the SEER database on 50,000 patients, seeing if there was an association with myeloma and other types of diseases. Well, AML has been known for a long time, and MDS has been known for a long time, and that's been associated with the long-term use of melphalan, which is an alkylating agent that if you use it for more than 18 months, virtually everyone develops either MDS or AML. We showed an association with myeloma and kidney cancer, but secondary malignancies are an issue because patients are living longer. So in this trial, we showed this was not designed for survival, but time in remission, even if you include the patients with secondary malignancies. At 4 years, 50% of the patients versus 23% of the patients were in remission. So lenalidomide does improve outcome. So if we look at the outcome of auto transplant, the average time to be in remission is 3 years, and failure is always from tumor. So lenalidomide is one way of preventing recurrence. Prior to that, we used thalidomide. This is the study that was published by City of Hope. They had 841 patients, median follow was 3.4 years. 7.4% at 5 years had malignancy, and nearly 16% at 10 years. They defined the risk as being over the age of 55, being non-Hispanic, and previous thalidomide exposure. They tried to look at the same data set with Revlimid, and there weren't enough patients. But now we have at least 3 trials that show that lenalidomide increases risk of malignancy. So the question is, how long do you treat them? Is it better to be in remission? Are there better secondary drugs to use like Velcade? So many of the patients, if they've had a previous clot or previous malignancy, I use bortezomib or Velcade because there's no associated secondary malignancies with it. Now, to be critical of some of these trials, the European trial started Revlimid at day 30. Well, once you give melphalan and you look at, if you did series of bone marrow biopsies, you would see adjunct defects in DNA that appear to get better at 3 months. So I think they probably started Revlimid a little too early, and that may account for the higher incidence of secondary cancers. But secondary primary malignancies will be a big problem in deciding future trials. So this is another mental error. I was out looking for pythons in the Everglades. The next patient is a 56-year-old patient who on day 10 her stem cell transplant had a fever 102, pulse 130, respiration rate of 30. Her SED rate was 50, lactic acid was 1, procalcitonin was 1. She had a skin rash, shortness of breath, diarrhea, and confusion. And this is what her skin rash looked like. So this is engraftment syndrome. So patients, if you focus on the bottom of this slide, they develop rash, fever, pulmonary infiltrates, capillary leak, weight gain. They get confused, diarrhea, and they can go on to multi-organ failure. And the reason for that is because you get cytokine activation, and it triggers IL-6, and it damages the bone marrow, liver cells, lung cells, and patients get quite sick. So when we think of engraftment syndrome, we do blood cultures and start people empirically on antibiotics, and once the cultures are negative, we start them on high-dose steroids with supportive care. The reason I brought up the engraftment syndrome, because the newer therapies, this is kind of the most common side effect. It only occurs in about 1% of patients with autologous transplant, but it's going to be the future. So I had lunch with Buzz Aldrin, and he's kind of a very interesting guy. He talked about Mars the whole time. He said it's there. He's there. He said it's there. It's waited to be walked on, and so he's volunteered to go to Mars. Everyone else in the group thought he was already there. So I think this is a good step-off point to the future of autologous therapies, and that's CAR T cells everyone's heard of. And this is, and how this works, this is the patient. They just leukapheresis them. They take these cells and engineer them. They put them in a viral salt bath, a viral bath that has this transcript here. You just incubate them like making soup. They are then expanded, and then the patients are given fludarabine and Cytoxan, and these cells are then infused back in the patient. This process takes 17 days, and these CAR T cells, this one is designed to be against CD19, and here's, I'll show you a cartoon of the CAR2 recognizes CD19, lyses and kill the cells. The nice thing about these T cells, they recruit normal T cells to kill cancer, and they can go into extra tissue sites. This is the recognition site. These are the CAR T cells. These are the T cells here. They recognize a specific isotope, whether it's HLA typing or the tumor-specific antigen. They interact and lyse the cells. And so this is the future of lymphoma and myeloma and leukemia care. So the side effects are, because it's a B-cell depleter, patients get hypogammaglobulinemia, have a higher incidence of infection, should get IVIG. Cytokine release syndrome is just like engraftment syndrome, but much worse. They dermatitis, they develop rash. They get what's called macrophage activation syndrome, which is basically you get pancytopenia and lymphadenopathy. You get neurologic dysfunction, cerebral edema, seizures. And so the cytokine release syndrome is associated with fever, hypotension, shortness of breath. You get anywhere from delirium, aphasia to seizures. You can just have jerking. This occurs within 1 to 14 days of infusing your T cells. And this appears more severe with the burden of disease. So patients who have CNS disease, like in leukemia, very high incidence. And so what happens, you have all these high growth factors, and one of the fellows at the University of Pennsylvania noticed that if you gave tocilizumab, which is an anti-IL-6 therapy, all their growth factors come down and their symptoms get better. So before they figured this out, it wasn't very transportable. So now 2 of the CAR T cells are FDA approved, one for diffuse large cell lymphoma and one for ALL. The trials for myeloma are just starting. I didn't show any of the data because the response rates are 90%, the failure rate is 90%. So they're just modifying the new drugs. So with that, I'll end this with another Creighton loss. But I only show this because my kid is in the background. But with that, I'd be happy to take any questions.
You had mentioned that you don't put them on maintenance therapy until the 100-day mark
I never do anything before day 100.
because of the risk of secondary malignancy?
So there was a study from Columbia University that looked at, you can look at peripheral lymphocytes and just look at DNA characterization. They showed, you can do something called SNPs. So you can look at chromosome defects. Well, after melphalan, that stays around for about 3 months and then gets better. So I've always thought it was a bad idea to add a drug that increases toxicity. So I just never did that. I'm sorry?
Which drug are you giving?
You know, this is very scientific how I decided. Because lenalidomide is $15,000 for 21 pills. And not everyone has coverage for pills. So those patients get Velcade, right? Or if they've had a complication, like the woman with that had that hypersensitivity reaction from her lenalidomide, I put her on Velcade. Patients who had a previous blood clot, I put on Velcade. Because the incidence of clotting, if you don't prophylax, is 16%. So they have a reason, so clotting can't afford it, I use Velcade. So Velcade hasn't been associated with any secondary malignancies. The problem is the trials aren't as robust as it is for lenalidomide, but it appears to be the same. Now, probably the best maintenance drug will be daratumumab. So on the surface, so there are resistance patterns for these drugs, whether it's Revlimid or Velcade, but on the surface of the myeloma cell is a CD38 antibody, and daratumumab is a monoclonal antibody that's directed to that area. So there is a study that hasn't been presented yet, but that's probably going to be the maintenance drug. Just like with lymphoma, the maintenance drug is Revlimid. Is not Revlimid, is Rituxan. And all these monoclonal antibodies deplete B cells, so you have to follow their IgG levels and replace them with immune globulin monthly, otherwise they'll have more infections. So all these patients get side effects, right? But you guys seem to manage them all quite well. Like the first patient I outlined, more than 80% mortality rate. By just supporting them, they get better, right? So you've managed all the side effects, they've all gotten better. Mortality rate is less than 1%. Morbidity is about 5%. When I first started doing this, mortality rate was 25%, and morbidity was about 20%. But we don't transplant, we do transplants early. We don't do them as a salvage therapy anymore. We transplant everyone early. Any other questions? Yeah?
Would the allogenetic patients be eligible for the CAR T or just the allos?
No, allos can't. So when if you failed an allogeneic transplant, you should be eligible, because when you collect those T cells are the allogeneic cells. So you probably can collect those cells from your donors. That's not how it's designed, but they're basically the same cells. Because you could do chimerism studies after an allo transplant to see donor and recipient. And if they're all donor cells, you collect the cells and engineer them. The problem with CAR T cells, how much do you think they cost? Yeah, so the cells cost $450,000. I can teach you all how to make those cells for about $10. But because they have good manufacturing facilities, it's $450,000. And if there's a complication, it costs about $1 million. So it's unclear who's going to be eligible for it. So there are CAR T cells now for lymphoma, ALL. There's one for AML that's being tested. There are CAR T cells for glioblastomas. There's a CAR T cell directed at pancreatic cancer, breast cancer, and colon cancer. Now those solid tumors are still being investigated, but it's FDA approved for ALL and lymphoma. So I went to the CAR T cell meeting last year. I thought I was in Switzerland listening to the economics talk. Everyone talked about the economics of it. And these physicians were deciding who should get treated. I'm not sure a physician should be doing that, right? Because I can tell you if I have it or if my family member has it and that's the best therapy, I want them to have it. But they're going to limit by age, type. So if you could predict they're not going to respond, I wouldn't treat them either. But there's no prediction of that. And for myeloma, so myeloma has a very unique protein in the surface called BMSA. So it's on all the myeloma cells. So there's a bunch of CAR T cells studies that show low toxicity rates. So this engraftment syndrome is quite low because you don't get brain involvement with myeloma. But 80 to 90% response rates, but at 9 months, 80 to 90% failure rate. So I'm not sure that's so I sent one of my patients to the University of Pennsylvania because they have it's BMSA, but then they have CRISPR, which is a genetic way of cutting out the defect. So I thought that was probably the coolest CAR T out there. So she'll be number 2 on the trial. You want to be number one in the trial for some reason, because they're the only ones that seem to respond. So Revlimid, or lenalidomide, is the #1 cancer drug. It's about $150,000 per patient a year. And the original trials for 1 year, but like the patient I had with leukemia, he was in year 7, he developed leukemia. So the secondary malignancies are a big issue. That's why Velcade may be a better choice, or Dara may be a better choice. All right, well, thank you very much.